Good afternoon. It's so great to be here finally at the end of all of this process. I'll echo Christy's sentiments about just being excited to finally be here presenting the end of this project. So my name is Natalie Hall, and I'm a nurse practitioner at Vanderbilt in the cerebrovascular neurosurgery department. And my DNP translational project was to implement an evidence-based protocol for cognitive dysfunction screening after aneurysmal subarachnoid hemorrhage. My DNP committee members, to whom I owe a huge thanks to, are Dr. Jackson and Dr. Froehler. In the United States, a stroke occurs about every 40 seconds, and around 3% of these are subarachnoid hemorrhages. The most common cause of subarachnoid hemorrhage is from a ruptured aneurysm. There is significant mortality and morbidity associated with an aneurysmal subarachnoid hemorrhage, with 1 in 4 being fatal and 1 in 2 survivors having a residual deficit. So although this is a small proportion of all strokes, it does carry a significant and frequent poor outcomes. In approximately 60 to 80% of aneurysmal subarachnoid hemorrhage survivors, a chronic cognitive deficit persists, and there's a loss of productivity from a stroke in the United States that's estimated to carry a $17.5 billion economic consequence, which is huge. 2 important guidelines for stroke care that serve as a foundation for this project are listed here. In 2017, the American Heart Association added the recommendation to refer patients after an aneurysmal subarachnoid hemorrhage for neuropsychological evaluation. And in 2019, the Collaborative Common Data Element Project recommended adding objective cognitive assessment as an outcome measure in all future stroke and aneurysmal subarachnoid hemorrhage clinical trials. So to accomplish this, we need effective and pragmatic solutions to implement these recommendations into routine clinical practice. And a lack of data on how to do that in the literature and in our clinical practice in the cerebrovascular clinic has served as the basis for this PICO question in this project. So the PICO question that drove this project is, in clinicians caring for aneurysmal subarachnoid hemorrhage patients in a cerebrovascular clinic, how does an evidence-based protocol for screening and management of cognitive impairment affect nurse and provider knowledge, compliance with screening recommendations, and number of referrals to neurology, neuropsychology, or cognitive rehab compared with current practice over a 6-month period? This project was a quality improvement study collecting quantitative data with outcomes measured by knowledge assessment tests and protocol compliance evaluations. The project took place at Vanderbilt's Cerebrovascular Clinic, where I work, with 3 physicians and 6 nurses. This team helps to treat about 100 ruptured aneurysms annually, which contributes to more than 300 annual visits in our practice in the clinic at varying times after an aneurysmal subarachnoid hemorrhage. The independent variable in this study was the education session. The dependent variables included the following: nurse and provider knowledge assessed by pre and post intervention test, volume of aneurysmal subarachnoid hemorrhage patients screened for cognitive dysfunction using the Montreal Cognitive Assessment Tool, or the MoCA tool, at the cerebrovascular clinic, and nurse and provider compliance with the cognitive dysfunction screening protocol. The project included a pretest, the education session, and an immediate post-test. Then the participants began implementing the evidence-based protocol in our clinic. Delayed post-test was performed mid-implementation to assess for retained knowledge from the education session. The pretest was delivered via paper test in person in late January of this year. The survey included 9 knowledge and application questions, with the higher score indicating a better understanding of the content. The surveys also asked specific questions about experience and confidence in using stroke-related outcome measure scales, including objective cognitive assessment tools. The education session was delivered after the pretest and was in person for nurse participants and by recorded Zoom for physician participants. This was about 30-minute PowerPoint presentation that included background and description of the project, purpose statement and PICO question, and presented a summary of existing evidence regarding cognitive assessment after an aneurysmal subarachnoid hemorrhage. It also described the MoCA tool with instructions on administration, scoring, interpretation, and how to document results of the MoCA score in the electronic medical record. It also included information about the evidence-based protocol to be implemented into practice. For those who may not be familiar with the MoCA tool, there's a picture of it on the left of the slide here. It is a readily available, free, and relatively quick paper test. It does not require extensive training, although I did become certified in the use of the MOCA as part of this project. It evaluates 7 domains of cognition and offers multiple versions to minimize learning effect when testing and retesting patients in a short time frame. The first post-test was administered to the clinicians immediately after the education session as a paper test, which was in person. This repeated the same 9 knowledge and application questions from the pretest. Implementation of the evidence-based cognitive assessment protocol began on February 1st and concluded on July 31st of this year. Prior to this, nurses shadowed me administering and scoring the MOCA, and then they were observed with at least 2 patients to ensure competency using the MOCA. Using this evidence-based protocol, the nurses reviewed inclusion and exclusion criteria when a patient arrived to the clinic. If the patient was included, the nurses administered and scored the MOCA test. Results of the test were documented in the patient's chart and were given to the provider. The provider used clinical judgment and results of the MOCA to determine the next steps. A cutoff score of 26 was used because the sensitivity and specificity for mild cognitive impairment at this cutoff score is 90% and 80% respectively. Patients who score less than 26 were referred to cognitive rehab. For those with a perfect score of 30 without a cognitive complaint, no action was needed. And for patients who scored a 30 but had a subjective cognitive complaint, and those patients scoring 26 to 29 were referred for neuropsychological testing. After about 2 weeks of implementation of the protocol, we encountered an unexpected challenge. A patient otherwise meeting the inclusion criteria was scheduled as a telehealth appointment. So unfortunately, the MOCA tool is not readily applicable to a virtual visit, so I pragmatically adjusted the inclusion criteria to include an in-person clinic visit. All participants were immediately updated on this change at the time of the inclusion criteria update. I provided reminders, knowledge refreshers, and was available for just-in-time questions and feedback throughout the project. At about 4 months after implementation, a delayed post-test was administered. This again contained the same prior knowledge-related questions and repeated survey questions regarding frequency and competence of performing cognitive assessment tools. Outcomes measured included the knowledge assessment at 3 time points, compliance with the protocol defined as patients successfully screened with the MOCA and referred based on the protocol, and patient outcomes on the MOCA and the modified Rankin scale. The modified Rankin scale is used as a standard outcome measure for stroke studies, and Joint Commission requires documentation of the modified Rankin scale score at 90 days post-stroke as part of stroke center certifications. It's a measure of disability or functional outcome on a scale of 0 to 6, with 0 being no symptoms or disability and 6 indicating the patient has not survived. So this is the most common outcome scale used in most clinical trials. For comparison data, chart review was conducted for the 6 months preceding project implementation. During this time frame, 11 patients were seen in follow-up after aneurysmal subarachnoid hemorrhage. None of those had a cognitive assessment despite 1 referral to neuro rehab. The nurse and physician participants were 66.7% female, and each of the 9 participants completed all 3 of the knowledge assessment tests. This chart depicts individual scores on each test scored on a 100-point scale. I realize this is a little busy, but I want to highlight that 7 of these participants demonstrated improved knowledge on post-test 1 compared with the baseline pretest, and none of the participants had a lower score on the first post-test than they did on the pretest. Similarly, the same 7 clinicians had sustained or improved knowledge on the final post-test compared with the baseline testing, suggesting knowledge retention. A paired samples t-test was used to compare pre-test with post-test 1 mean scores, which did show a statistically significant improvement in scores with p equal to 0.005, immediately following the educational intervention. There was no statistically significant difference between the rest of the test scores, but the post-test 2 scores were still higher than baseline, suggesting knowledge retention. During the study, the average number of cognitive assessments performed per clinician increased from 0.2 to 3, and the average competence rating increased from 3.4 to 5.8 on a 10-point Likert scale, indicating both increased frequency of use and increased confidence in using a cognitive assessment tool in our practice. This is a flowchart of patient encounters during implementation. There were 20 patients seen in first aneurysmal subarachnoid hemorrhage follow-up, with 16 meeting inclusion criteria. Of these, 15 were screened with the MoCA tool, and majority were referred to cognitive rehab. 2 were referred to neuropsychological evaluation, and 2 patients deferred the recommended referral. Clinician compliance with the protocol for cognitive dysfunction screening and management was observed in 93.8% of eligible patient encounters. Compliance with the protocol-driven referrals to neuropsychology or cognitive rehab based on the MoCA score and clinical judgment was observed in 100% of encounters for patients who were screened with the MoCA. Before project implementation, 0 patients had cognitive assessment, compared with 93.8% at the conclusion of this project. This was a dramatic increase in compliance with evidence-based recommendations for cognitive assessment in this population. A sub-analysis was performed on the MoCA scores compared with the modified Rankin scale scores. A mean MoCA score across all patients was 21.2, with range of 8 to 28. And if you recall, less than 26 is considered cognitive impaired. So cognitive dysfunction, or less than 26 on the MoCA, was identified in 86.7% of our patients. Interestingly, on baseline clinician surveys, most clinicians anticipated that 40 to 60% of our aneurysmal subarachnoid hemorrhage patients would have cognitive dysfunction, which was definitely an underestimation in this group. Differences in modified Rankin scores between the cognitive dysfunction group and the cognitively intact group were not statistically significant. The majority of patients, so 73.3%, had what's typically defined as a good functional outcome by modified Rankin score being 0 to 2, despite having a poor MoCA score, suggesting that the modified Rankin score does not accurately depict cognitive status after aneurysmal subarachnoid hemorrhage in this sample. The MoCA score range was 13 to 28 for the group with good functional outcome on the modified Rankin scale, and was 8 to 11 for the 2 patients with the higher modified Rankin score. Prior to project implementation, long-term goals were defined as successful screening of at least 70% of included aneurysmal subarachnoid hemorrhage patients with the MoCA, compliance with the protocol in at least 50% of patient encounters, and at least 50% of clinicians having sustained knowledge at post-test 2 compared with post-test 1. After the 6-month implementation period concluded, the long-term goals were exceeded. At project completion, 93.8% of eligible patients were screened with the MoCA. Compliance with the evidence-based protocol was observed in 93.8% of encounters, and 55.6% of clinicians had sustained or improved knowledge change between post-test 1 and post-test 2. Furthermore, 77.8% of clinicians had sustained or improved knowledge change between baseline testing and the final post-test. So each predefined short and long-term goal was exceeded with this project. In this study, 86.7% of patients screened with the MoCA tool had cognitive impairment, which is slightly higher than the literature reported 60 to 80% of aneurysmal subarachnoid hemorrhage survivors having a chronic deficit in cognition. While this is not wildly different, this discrepancy suggests that some patients may experience improvement in cognitive dysfunction over time beyond this first follow-up visit where we assessed it, therefore not experiencing chronic deficits. The majority of patients did exhibit cognitive dysfunction by MoCA score despite good functional recovery on the modified Rankin scale. This finding is consistent with reports in the literature suggesting that more than half of aneurysmal subarachnoid hemorrhage survivors with good functional outcome may have cognitive impairment, and this may be an underestimation. Screening only with the modified Rankin scale to understand outcome after an aneurysmal subarachnoid hemorrhage is inadequate to identify the substantial cognitive dysfunction within this patient population. In summary, there was a significant improvement in clinician knowledge of the problem immediately after the education intervention, with most participants retaining knowledge on delayed retesting. The intervention and knowledge change did translate to a successful change in practice, with an increase from 0 to 93.8% of patients being screened for cognitive dysfunction before and after the intervention, respectively. Limitations of this study include small sample size, limited generalizability, and a shift to telehealth during the project. The subspecialized nature of the healthcare team that provides care for a rare stroke subtype makes for a relatively small sample size of both clinicians and of patients, and this also limits the generalizability of these results. The COVID-19 pandemic may have affected the volume of patients seeking follow-up care after experiencing an aneurysmal subarachnoid hemorrhage, and it definitely has accelerated the shift to telehealth to minimize contact with others in our practice, and I assume most of yours as well. And this project was not easily adapted to telehealth in real time during implementation. The MOCA tool used in this project is a paper document, so it requires the patient to be in person for full participation in the cognitive assessment using the MOCA. For patients who can participate in cognitive assessment with the MOCA tool after aneurysmal subarachnoid hemorrhage, performing routine reassessments beyond the first follow-up visit will help establish individual trends and monitor for effects of early intervention. Further research is necessary to understand the impact of early cognitive intervention on long-term outcomes for patients with cognitive impairment after an aneurysmal subarachnoid hemorrhage. The theory of symptom management, which is the philosophical framework of this study, may be applied to support future research to understand the patient's perception of cognitive outcomes with usual practice compared with early identification and aggressive interventions addressing cognitive impairment. Future stroke and aneurysmal subarachnoid hemorrhage studies should include cognitive status as a standard outcome assessment in addition to the modified Rankin scale for functional outcome, as the modified Rankin scale does not adequately assess cognitive outcome. In conclusion, the quality improvement study involving a single educational session had a positive result on nurse and provider knowledge of post-aneurysmal subarachnoid hemorrhage, cognitive dysfunction, and on compliance with screening recommendations. This successful project has described one strategy for translating current best evidence into clinical practice for consistent screening and management of post-aneurysmal subarachnoid hemorrhage cognitive dysfunction with a small budget, no capital expenditures, no changes to staffing, and minimal disruption to existing clinical workflows. The information has been disseminated locally to the cerebrovascular clinic staff and on a broader scale by e-poster at the Society of Neurointerventional Surgery conference this summer, and project results were briefly shared during a podium presentation on stroke clinical scales earlier this week at the Association of Neurovascular Clinicians conference. An abstract has been submitted for poster presentation at the International Stroke Conference in 2022. This project may contribute to the MOCA tool becoming a standard of care for cognitive assessment after aneurysmal subarachnoid hemorrhage and contribute to early intervention for identified dysfunction. I've met each of the DNP essentials over the past 2 years, but I'll highlight essential 3, 6, and 8. Through this project and the coursework throughout the DNP program, I've become more confident in critically appraising literature, designing quality improvement projects, and analyzing data from practice. I've developed collaborative relationships across disciplines with neuropsychology and health IT teams as part of my work with this project, and it's provided opportunities to educate and mentor nurses within my clinic and serve on committees within several professional organizations to improve neuroscience nursing practice. So finally, in addition to my DNP committee, I'd also like to thank Carolyn Knoll at Vanderbilt for her health IT support and Vanderbilt neuropsychology colleague, Dr. Considine, for his input regarding the planned protocol for screening and referrals. And of course, the Vanderbilt Cerebrovascular Clinic physicians, nurses, and support staff for their eager engagement in this project. There's a long list of references here, and I'd be happy to take any questions.
Thank you so much, Natalie. We'll open it up initially to your committee for feedback and questions.
I guess it's me and you, Joni. You go first.
I just wanted to thank you, Dr. Froehler, for all of your help and guidance and support of Natalie's project. And again, our community members are all champions, and we appreciate your time.
Well, same to you. I really appreciate your guidance and mentorship for Natalie. This has been a great thing for me to witness, and I think really this project in particular has been a real boon to our practice, to our clinic staff. The recognition that subarachnoid hemorrhage so frequently, I mean, nearly all the time, causes some cognitive dysfunction is really important. And this kind of gets into one of my, content comments, but it's interesting that it happens so frequently, but it's subjectively often not realized by patients. So, Natalie and I years ago, when this was just not even an idea yet, talked about patients returning to work and patients thinking that they're ready to return to work, but then getting frustrated that they can't do the accounting that they used to do, or, whatever task it was. And the interesting thing that's now borne out by Natalie's project is that the modified Rankin scale really depends on the patient's subjective account of how they're doing motor-wise, but also if they have significant cognitive dysfunction, that should be reflected in dysfunction on the modified Rankin scale, but it's not there. And it's because patients aren't recognizing it. That's why having an objective scale like the MoCA is so important. I think that's one of the main takeaways for me from Natalie's project. So thank you, Natalie, for doing this, for presenting it to the group, and for allowing our clinic to participate.
Thank you so much. I really appreciate all of your support and all the clinic. I mean, everybody at the clinic's enthusiasm in this project has really what's made this successful.
What do you hear from the other side, from the cognitive folks? What have they said about seeing these patients?
It's been positive. There's only been a couple that have been referred to neuropsychology so far anyway. Dr. Considine has been a cheerleader of this project, which has been really helpful in engaging with that group.
And have you heard from patients who have gone through cognitive rehab and what their experience of that is?
So yes, while it's not included in the study, I have kind of kept track of these patients to see at 6 months, and a lot of them have kind of come up on that time frame what their MoCA score is. Many of them, their follow-up has been by telehealth, so that makes it challenging. But the couple, at least in the last couple of weeks, that have returned, there's 2 of them that I wrote down because it was really impressive. The first one was she had a MoCA score of 8, which was actually the worst MoCA score that we had, and a modified Rankin score of 5, which is one step, below being dead on the modified Rankin scale. So she had initially a really poor outcome. And at 6 months, her MoCA score was a 19 and her modified Rankin score was a 1. So she dramatically improved, but I would love to say that it was all because of the cognitive rehab. But she also was found to have delayed hydrocephalus. And once that was treated with a shunt, that obviously helped too. So I think that may be interesting to see if we can find any kind of pattern as well, with the significantly lower MoCA scores, maybe suggestive of possible hydrocephalus. So
Yeah, right. Yeah. So do you think that this is another way that we can be screening for other, delayed sequelae of subarachnoid hemorrhage? I mean, the one patient that you just described, did we already have a CT, or did this prompt getting the CT?
We did already have a CT for this one, but I agree. I've thought about that. It would be interesting to see in patients who maybe don't get a CT, or even, who do, if we could use this kind of as a surrogate for a CT in those patients.
Yeah. Cool. Well, great job. I won't hog the floor, but let's see if Joni has any other questions or comments.
A great project, and I think that this will have far-reaching implications for a lot of different things. So thank you, Natalie.
Thank you all so much.